I'd like to talk the new diuretics for the treatment of heart failure. And today I just touched on the two new inotropic diuretics, new diuretics. One is the Vasopressin antagonist, and the other is the Adenosine antagonist. As you know, as the other neurohumoral factors in heart failure, this slide shows the plasma vasopressin is increasing with the severity of the heart failure. The New York Heart Association class 4 is the plasma vasopressin is increased. And algin vasopressin, another name is the antidiuretic hormone, they stimulate V1A receptors. These are the vasoconstriction and increase in the afterload. And V1A is the just like alpha stimulation of adrenergic stimulation, LV hypertrophy or remodeling induced. However, V2 is the water retentions. So if we stimulate water retentions, then hyponatremia in heart failure is some serious problem. And this is also contribute to the increase in preload. So in that scheme, the inhibition of the algin vasopressin should be effective to reduce the afterload and also the to improvement of hyponatremia in patients with heart failure. And this slide shows that even in the heart failure with reduced ejection fraction or heart failure with preserved ejection fraction, hyponatremia is getting worse in the prognosis in both entity of the heart failure. Tolvaptan is the selective V2 receptor antagonist, and this shows the V2 receptors. And the Tolvaptan here is the very closely fit the three-dimensional structure of the receptors. And here is the OPC 41061 is the Tolvaptan. And what side the Tolvaptan V2 antagonist works is here. Ascending beam of the loop diuretics is action here. Thiazide is action here. Aldosterone is the action here in the correcting tubule. And Tolvaptan and algin vasopressin is the acting here. And you can see the magnified this area. V2 receptors is located on the basolateral membrane. This is the vessel, and this is the principal cell, and this is the correcting tubule duct. And V2 receptors are located here. And if we stimulate V2 receptors, then it phosphorylates the aquaporin 2, and this is the wrapped by the vesicles and recycling in a cell. And stimulation by the AVP by V2 receptors. So aquaporin moved to this luminal membrane, fixed into as a water channel. That means the permeability of the water is increased and water transferred inside. And further, through apocrine 3 or apocrine 4, this is the incorporated in the vessel. So the stimulation of V2 receptors is the increase the permeability for the water to reabsorption of the water is increased. So Tolvaptan inhibited this V2 receptors. That means the absorption of water, free water, is inhibited by this drug. And looking at in a normal conscious beagle dogs, This shows the urine volume. Urine volume is dose-dependently increase. This is a furosemide. Furosemide is also dose-dependent increase. And this is the urinary sodium secretion. But Tolvaptan does not increase sodium excretion, whereas furosemide increases dose-dependently. This is a clear difference in the furosemide. And this is the osmolarity. Urine osmolarity is the dose-dependently decreased, but furosemide doesn't so much. So this is the free water clearance. This is a very clear difference between the furosemide and Tolvaptan. That means the water clearance is increased with the dose. So in the human phase 3 trial, the QUEST study in Japan, this is multi-center randomized double-blind placebo-controlled parallel group study. And when the patients with the heart failure is hospitalized, after running period, Tolvaptan 15 milligram per day is every 7 days. And these are in a hospitalization, and the concomitant, usually the furosemide is a constant dose and remain. Look at this urine volume. This is a change from a baseline. So the even after 1 day, first days, urine output is increased. About 1 liter per day is increased on the top of the furosemide effect, and that continues for 7 days. The water intake is a free. That means water intake is not prohibited. So this is the depend on the thirst of the patients. Water intake is free, and urine volume is rather than the water intake. And endocrinologic parameters, plasma albumin vasopressin is increased by the blockade of the V2, and osmolarity is increased a little bit in 7 days, and BNP in both furosemide and Tolvaptan is a little bit decreased, and plasma renin activity is slightly increases, but not so much. Interesting is that the serum sodium is slightly increased, and in the patient with hyponatremia, then the serum sodium increases more than the normal patients. And serum potassium doesn't change at all. This is a very critical difference from the furosemide. And blood pressure and pulse rate doesn't change. So it's very good news for the patients for the heart failure. The hemodynamic change is not observed. In Everest trial, this is the long-term, the combined of the short-term trial and long-term trial. And 2 short-term trial, here and here. This is separate. And 4,000 patients enrolled, and oral Tolvaptan 30 milligram. And this trial B is a different populations, the same protocol, to check the difference or the equality of this trial. And after that, following up, combine a long-term outcome trial. So this short trial, only 7 days. And primary endpoint, the composite of change of body weight and improvement the patient-assessed global status. Look at this. This is the additional weight loss on the furosemide. So 0.6 kilogram and 0.9 kilogram, trial A and B is reduced That means the body weight is reduced. However, the patient assessed global clinical status doesn't change. If we observe the physician-assessed signs and symptoms, then dyspnea is improved, orthopnea is improved, and the fatigue is improved, and edema is improved. So in this short-term trial, this difference in the patient-based assessment and physician-based assessment are a little bit different. The physician is the assessment is a better outcome for the dyspnea or orthopnea, fatigue, or edema. However, this Tolvaptan is administered more than 60 days, and 1 year follow-up, the long-term follow-up, the all-cause mortality or the mortality and heart failure hospitalization doesn't change. So this means Tolvaptan did not improve the prognosis of the patients, although in a short period, there's some improvement of the symptom. Physician-assessed symptoms is improved with the body weight loss. So in well-treated patients hospitalized with heart failure, oral Tolvaptan 30 milligram daily facilitated management of volume overload with early and sustained weight reduction, improvement of dyspnea or edema, however, no effect on the global clinical status at day 7, and normalization of serum sodium and maintenance of renal function. And long-term treatment had no effect on long-term mortality or heart failure morbidity. Tolvaptan achieved short-term symptom benefit with a well-defined and acceptable long-term safety profile. So this Tolvaptan is a selective V2 receptor antagonist with aquaresis, water secretion effects that increase water secretion but not electrolyte excretion. Studies in the United States and Europe, this is the Everest study, demonstrated the efficacy of dose titration from 15 to 30 to 60 milligram Tolvaptan administered once daily in patients with hyponatremia. In Japan, the recommended dose is 15 milligram once daily. And while short-term benefit of Tolvaptan have been demonstrated in a clinical trial, long-term effect on the prognosis of patient has not been shown in Everest. So the future studies should be investigated long-term effect of Tolvaptan in terms of mortality and morbidity. However, in Japan, this drug is indicated, and Japanese PMDA accepted as a treatment of the volume overload in patients with heart failure. So 3 years, we can use this diuretics to control the water control in patients with heart failure. Another topic is a new diuretic drug, Larofin, as an A1 receptor antagonist. Adenosine is the well-known, it's a multipotent effect in the multiple organs. But for the kidney, A1 receptor stimulation, antidiuretics, antinatriotics, and renal vasoconstriction is bad for the kidney. That means if we block adenosine A1 receptors, then diuresis increase and renal vasoconstriction is released. That means may be the benefit for the renal impairment. So adenosine A1 receptor stimulation and reducing renal blood flow, reducing GFR, inhibiting renin release, or enhancing proximal tubular sodium reabsorption. That means rationale for the A1 receptor antagonist may be a promising drug for the good diuretics. So this KW 3902 is the Larofin, and those dependently increase up to the 30 milligram, the urine volumes increase. And this is a crossover study the lorofilin is here, open circle here, as increase the filtration rate, and switched crossover, and this is the placebo, this is the lorofilin, is increase the GFR. So the several phase 2 trial is a promising result. And finally, the phase 3 PROTECT trial was conducted in the 2,000 patients with heart failure, acute heart failure with renal impairment. And lorofilin 30 milligram for 3 days. As you can see, the result is disappointing. And this is the treatment success. And this is no change patient conditions. And this is treatment failure. As a placebo and the lorofilin doesn't change. And this is the outcome of the PROTECT trial. And this is the death and readmission of the hospital. And this is death, both outcome doesn't change with placebo. And if you look at the adverse event in the PROTECT trial, the worsening renal function is the lorofilin, and this is the placebo, is the comparable. Early death is comparable. Early worsening heart failure is comparable. Early readmission of heart rate is comparable. Death and the cardiovascular readmission is comparable, even higher. And 6 months death is comparable. And as an adverse effect, A1 receptor antagonist decrease the threshold for the seizure. So the cramp in some patients observed. So the development of this lorofilin is stopped, and we cannot use this drug as in the clinical use. And conclusion of the lorofilin study is a new diuretic agent, adenosine A1 receptor antagonist. This may preserve the GFR, enhance sodium excretion, improve diuretic responsiveness. Lorofilin given with loop diuretics enhance diuresis up to 6 hours associated with urinary excretion, sodium chloride, calcium, magnesium, and while remaining renal function. In phase 3 PROTECT trial, patients with acute heart failure or impaired renal function were studied with lorofilin 30 milligrams up to 3 days. In contrast to the favorable result in the pilot study, PROTECT study did not show any benefit in prognosis, heart failure status, and renal function. So the lorofilin is not available for the clinical use. So today I talked to the two agents. One is Tolvaptan, and the Tolvaptan is not on the clinical use for the United States. United States indication only for the hyponatremia. In Europe is also only for the hyponatremia. In Japan, and I hear from Taiwan, India is also available for the heart failure with volume overload. Thank you very much.
Thank you, Professor Hori. The topic is open for discussion.
Thank you very much for your interesting talk. My question is regarding the Tolvaptan. Is it going to be, this drug replace the conventional therapy like furosemide in the future? If, for example, you have patients with heart failure and hyponatremia, will you going to stop the furosemide and replace or swap the patient to Tolvaptan, or you still give the patient furosemide as a constant or low dose and add the Tolvaptan on top of that?
Okay, thank you very much for the questions. We have our experience 3 years, and actually the Tolvaptan is very effective, the hyponatremia in heart failure patients. And acute heart failure, we admission in the hospital, the hyponatremia. At that time, we add the Tolvaptan on the top of the furosemide. Furosemide treatment is continued, and on the top of that, the Tolvaptan for Japanese people is a 7.5 milligram, small dose, or 15 milligram. But response is sometimes a very remarkable response. That means water excretion in 3 liter per day. Oh, surprise! It's water overload is quickly reduced, and some patients 1 liter. So it's very hard to speculate, predict how much of the water secretion is okay. So we start usually the 7.5 milligram. It's very successful, and increase the sodium, so the serum sodium 1 day or 2 days, 3 days, as usually normalize in the normal range.
I should say we participated in the Everest study, and I think we could hardly call it a blinded study because everyone knew who was taking the active drug. The diuresis was always fantastic. So it's hardly a double-blind study as it's supposed to be. There is a question over the first one, the first gentleman. Yes.
Any effect on the diuretic resistance? Do they cause any diuretic resistance?
Well, we propose the furosemide resistance patients, and Tolvaptan is very effective. If we control the furosemide, the high volume, then actually no need for to add Tolvaptan on that patients. So the furosemide resistance is one. And then second is the sodium, serum sodium is decreased at the hyponatremia or very close to the hyponatremia. Tolvaptan is very effective to reset up the condition of the patients. So after 1 week, we stop at Tolvaptan, and we can manage to in a normal range of the sodium level. So it is not so long-term administration of the Tolvaptan. We do nothing consider that it is not a good way.
Very much enjoyed your elegant presentation. I just have 2 queries because we do use in our practice. One is that, 2 fears that it may not cause and result in hypernatremia. And second is monitoring the liver function test. That okay, you should, because there may be, there is a fear of toxicity to the liver. In your large experience, what are your,
Well, it is reported that in patients with severe heart failure, more than 20% of the patients is hyponatremia. And the hyponatremia is the poor prognosis. So I think it's a early start restoration of the sodium level is very important. And as I show in this slide, the Tolvaptan in a high volume overload is a very effective free water. So the increase, in clinical point, the very important is that the water intake should be free. And in early days in Japan, and the patient who do not drink water, we give the Tolvaptan. That means intake water is limited. So the sodium, serum sodium, increase more than 146, or some patients it's a very dangerous, sodium increase. So you should keep the patient with a free water drink, depend on the thirst. Then we can easily control the 3 days or 4 days administration of a Tolvaptan is very effective.
The last question.
Switching to the adenosine receptor A1 antagonist, KW3902. I wonder whether there's any data out there about their effects, their direct effects on the heart, per se.
Right.
Direct actions on the heart.
Right. Adenosine is also as a key molecule of the ischemic preconditioning. So the A1 receptor stimulation is a benefit for the heart from ischemic insult. So A1 receptor antagonist might be the worst, is that harmful for the ischemic heart. However, there is no data about that. And this trial, PROTECT trial, there's no acute myocardial infarction, so the very happy. But some adverse effect might be, keep in mind. One adenosine receptor antagonist. Yeah. Sorry.
What about the use of Tolvaptan in patients with liver cirrhosis and ascites?
Well, now in Japan, we did a study for the hepatic edema. And due to the liver cirrhosis. And now it's a very good data. And last month or two months ago, the hepatic edema is indicated for the Tolvaptan. And we are now trying to the polycystic kidney with a large dose of Tolvaptan, 60 milligram. So to your question, the hepatic edema is indicated in Tolvaptan.
Thank you, Hori, for your lecture, and the session is adjourned.
Thank you.
Thank you.